Welcome back to the ProPA podcast. I'm your host, Prof. G, and you're listening to another episode in our MSK101 series, where we break down the musculoskeletal and rheumatologic conditions straight from the PANCE blueprint. In this episode, we'll be covering adult-onset still disease, a rare but high-yield systemic inflammatory disorder that can present with vague symptoms like fever and joint pain, so it's often missed or misdiagnosed. We'll go through the Hallmark features, the diagnostic workup, and how to manage it on the boards and in real life. Let's dive in. Did you know that adult-onset still disease often presents with fevers so regular that they spike at the same time every day? In fact, it's sometimes called a quotidian fever, which comes from the Latin quotidie, meaning each day, and that classic clockwork timing is a huge diagnostic clue. All right, let's look at the kinder patho. What is adult-onset still disease, or AOSD? It's a systemic autoinflammatory disease of unclear etiology. It's thought to be triggered by a combination of genetic susceptibility and environmental factors like infections. It shares features with systemic juvenile idiopathic arthritis, or JIA, but in adults. Cytokine release, especially interleukin 1, interleukin 6, and interleukin 18, drives the inflammation, leading to fever, rash, and arthritis. All right, so how do these patients typically present? Well, there is a classic triad of adult onset still disease. First, there is a daily quotidian fever, which are spiking fevers often above 39 degrees Celsius, and they usually occur in the evenings. Secondly, patients often get a salmon-colored evanescent rash. Typically appears with the fever. As a side note, the word evanescent means something that fades away quickly or doesn't last long. And the third symptom in the classic triad is arthritis or arthralgia. Usually it's symmetrical and it involves the wrists and the knees. Other symptoms of AOSD can include sore throat, which is often an early sign, lymphadenopathy, hepatosplenomegaly, serositis like pleuritis or pericarditis, and myalgias and fatigue. All right, now for the workup and diagnosis. There's no specific test, so diagnosis is clinical, often using the Yamaguchi criteria. Common lab findings include leukocytosis with a neutrophilic predominance, a very elevated ferritin, often above 1,000 and sometimes above 10,000. We also see an elevated ESR and CRP, which is nonspecific, some mild anemia, and a negative ANA and rheumatoid factor, which helps us rule out other rheumatologic diseases. Remember, we must rule out infection, malignancy, and other autoimmune diseases before diagnosing AOSD. All right, now let's talk about treatment. So, first line treatment for AOSD is going to be NSAIDs or glucocorticoids like prednisone for the acute symptoms. If steroids are ineffective or for long term control, we can include methotrexate, especially if arthritis is prominent. We can also consider using biologics like IL-1 inhibitors or IL-6 inhibitors. And we want to monitor for complications like macrophage activation syndrome or MAS, which is a rare but life-threatening hyperinflammatory state. All right, next up is the book med versus the street med. So book med, the patient shows up with daily fevers, a salmon-colored rash, joint pain, and labs showing sky-high ferritin and leukocytosis. Boom, Still's disease. Very easy. Street med, however, in real life, the diagnosis is often tricky. Patients may be passed from doc to doc with nonspecific inflammation or misdiagnosed with infections or even cancer. The key is in the pattern: daily fevers, rash with the fever, joint symptoms, and the extreme elevation in ferritin. All right, now let's wrap up with some clinical pearls. So we're going to see daily fevers plus a rash plus arthritis, and that's when you want to think still disease. Ferritin is extremely elevated, often more than any other cause. Remember to rule out infection and malignancy before settling on a diagnosis. ANA and rheumatoid factor are usually negative, and biologics target IL-1 and IL-6, key cytokines in pathophysiology. All right, now let's do some PANCE style practice questions. Question 1. A 32-year-old woman presents with fevers up to 39 degrees Celsius every evening in the past week. She also has joint pain and transient salmon-colored rash that appears on her trunk during when the fever spikes. Labs reveal a WBC count of 15,000 with a neutrophil predominance, an ESR of 95, and a ferritin of 5,800. ANA and rheumatoid factor are negative. What is the most likely diagnosis? Is it A, rheumatoid arthritis, B, systemic lupus erythematosus, C, adult-onset still disease, or D, a viral exanthem? I'll give you a few seconds to think about it. If you said C, adult-onset still disease, you are correct. Remember, daily fever spikes plus evanescent rash plus high ferritin equals classic AOSD. Question 2. Which of the following laboratory findings is most characteristic of adult-onset still disease? Is it A, anti-CCP antibodies, B, elevated ferritin, C, low complement levels, or D, elevated creatine kinase? I'll give you a little bit of time. If you said B, elevated ferritin, you are right. Ferritin is often massively elevated, and it's a major diagnostic clue. All right, some final thoughts. Adult onset still disease may be rare, but when it shows up on the PANCE or in the clinic, you'll want to spot that classic triad of daily fevers, salmon-colored rash, and arthritis. Keep ferritin in your back pocket as the giveaway lab clue. Thanks for joining me on this MSK101 Clinical Medicine Brief. Be sure to comment, like, or subscribe to this podcast so you never miss an episode. And as always, this is the ProPA podcast, where future pros in medicine are made. Catch you in the next one.